Hello, I'm sharing a case of diverticulitis with a colovesicular fistula. This is an elderly individual who had had this for several months. Initially, the family was hoping to avoid surgery, but she continued to develop urosepsis, and we elected to do a resection. I'm just showing the steps. I left the fistula takedown completely unedited because I thought that that was the money of this operation. But I'll start with a medial to lateral dissection. This is my usual routine for benign and malignant disease. And I find that in cases of really bad diverticulitis with phlegmon, this dissection, this plane tends to be unviolated comparatively to the lateral plane. So I like to start in it and go as far lateral as I can. So there I've identified the ureter, and now we'll go and isolate the superior hemorrhoidal. You can see the left colic there just above the superior hemorrhoidal. We'll take the tension off and divide this. And we'll continue some medial dissection to go out as far as we can because we know the lateral dissection is going to be hard. So I really like to identify the ureter from this plane so that I know that when I start laterally, the ureter should be in an already dissected plane with a sponge on top of it. We'll get our sponge underneath there, all the way out lateral. And now we'll do some lateral dissection. I've been working with some GYN fellows recently, particularly for cases in the deep pelvis and with some natural orifice extraction. So I have my fellow working here doing some lateral dissection. And we'll go ahead and come down onto our sponge. And you can see how that's so helpful so that we know that we would never have got to our ureter before we would have seen our sponge, even without the ICG. And we'll continue to do some of that dissection. I don't show a lot of the lateral mobilization, but I'm going to continue to mobilize the sigmoid going down to this phlegmon, which is to the left dome of the bladder. This is one of my favorite moves or views in all of surgery, looking down the left side of the TME plane, particularly in cases with horrible phlegmons. I feel like it's always possible to achieve this type of view where you can really safely know where to dissect. You'll need to alter as you dig into deep holes and fall back onto our principles of surgery, which is work where easy, and go from known to unknown. So you'll see me kind of rotate around here, going all the way over to the right side and working my way back to the middle. The patient still has a uterus, so I know I'm going to come up to that in a second. That's the intramural abscess in the wall of the bladder. And I'm trying to get this down off of the bladder and behind it the uterus. Go work in another area. You can see there I've actually split the colon open at the level of the fistula, so I have to carve back into the plane here between the wall and the bladder. Trying to bluntly separate that. Pointing out the uterus, bladder, and ureter down there. Here I got into a little bit of a plane behind the uterus. This is allowing me to do a little bit more of this lateral mesorectal dissection. And then right on the back of the uterus here. This is where the bladder and the uterus are fused to the level of the fistula, but finally getting it down. This is a rim of colon wall that I inadvertently left up on the fistula, and I'm taking it down right here. I just wanted to see if any urine was leaking back by checking ICG there. It's a quick, easy way to know if you're going to need to do a bladder repair. And now I just have to get the colon off of the back of the uterus, and the lateral attachments are all done. And that's it. With that, we'll just finish up our lateral and medial mobilization. I did mobilize the rectum quite a bit to help it elevate out of the pelvis. I'll suspend the uterus to keep it out of the way and free up one of the arms. I'm not using an assist port, which is my usual. And then we will perform a transvaginal extraction. I felt that the specimen was too large to do a transrectal extraction. Here you see me mobilizing the flexure, just showing that I got that done. But I'll do a transvaginal extraction for specimens that I'm not going to chop up. She had not had a colonoscopy in many years, and on the off chance there's an occult cancer, I won't morcellate it. So I'll do a transvaginal extraction because I know that just about anything will fit. In a man with a case like this, I probably would have made a fan and steel and not done a transrectal extraction just due to the size of the phlegmon and not wanting to morcellate the specimen. I have now port hopped over to arm 2 so I can staple through the rectus, which is through arm 3. I usually have my stapler in while the ICG is going so that I can immediately staple. I do this proximally. I'm not as concerned for the rectal side, but there's usually still ICG in the rectum when you get down there to staple. With the specimen separated and reach not an issue, I'll go ahead and elevate the rectum out of the pelvis to identify the pouch of Douglas. I'll put an EEA sizer into the vault, and then I will cut right on the sizer just beneath the cervix and the posterior fornix, and we're able to pass things in and out. So the specimen I'll put inside of a bag. Again, anybody who hasn't had a colonoscopy, to prove that there isn't a cancer, I'll do this. Or if it was a cancer, I would do this. And then we'll go ahead and extract. What I like to do is on the other end is open up the bag, grab the colon staple line, and start to pull so it's not wadded up into a ball. And it tends to come out okay. It will always tear your vaginotomy. And the key is with closure to ensure that you get the mucosa and the muscle wall. And so that's what my inner layer here is. It's for strength and hemostasis. I'll let the fellow take over in just a moment. And we'll continue sewing. After we do the mucosa and muscle wall, we will then close the peritoneum over the top, more or less like a 2-layer closure. And by having elevated the rectum out of the pelvis, with the mobilization, when we end up making our anastomosis, the thought being is that it won't sit directly on top of the vaginal suture line. Always a concern of developing a fistula due to the two opposed suture lines. The right corner of the vagina was a little bit challenging, so I took back over to help clear this up. And then we'll go ahead and close the peritoneum over the top. I will always try to get some tissue interposed between the vaginal suture line and the rectal suture line. I usually do that with omentum. In this case, I did mobilize a omental fab off of the right side of the transverse colon so that it reached down to the deep pelvis and separated the rectal staple line or suture line and the vaginal suture line. I'm just showing where to suture to, not to get lost and to spiral out of the way. You have to be careful when you're doing this. Your camera is in 30 up, but it's actually below your sacral promontory, as are your hands. And so as you're suturing and moving the camera or pulling towards the camera, you can actually bang directly into your iliac sacral promontory and cause bleeding on the presacral venous plexuses. So you really have to be careful. That's why you saw the fellow pulling through kind of like this right here, not pulling too far and definitely not off screen. So I did do a hand-sewn anastomosis. It's the same one you've always seen me do. I'm just setting things up really clearly for our fellows so that she can learn the ergonomics of things. Working with all hands, trying to be efficient, showing her there that you can go through in one without having to transition the needle. Like that. And by working with arm 1 and 2, keeping unbelievably perfect, impeccable exposure for these bites with stability and good vision, and we'll go ahead and we'll tie to this post. We'll go ahead and do a leak test. I have yet to do a leak test on a sewn anastomosis that has bubbles. I don't think that there's any clinical correlation to that. I did leave a drain. I do test the bladder, which you'll see in a second, with about 300 cc's of diluted methylene blue. There was no bladder leak, so in cases like this, I will not leave. I will not do a bladder resection or repair. I will just leave a drain for 72 hours. So my algorithm for patients like this is a Foley for 48 hours, then removal, leave the drain for 24 more hours, check it for creatinine, and when it's normal, send them home without a drain on day 3. And that's what happened with this individual. Thank you for watching. I hope you enjoyed.